I do want to point out the mouth because it's often overlooked in that EMNT. I encourage you on your audit sheets to actually write out the M in there rather than just abbreviating it ENT. That way you are paying attention to noticing if there is some kind of mouth area finding that should receive credit. So let's go ahead and look further into this one count rule. An auditor's dream is finding the practice that forgets this rule when it comes to the easy to get credit for constitutional system. See if you're an auditor's ticket to vacation with this test. Here we have an example with weight 186, height 66, BP, pulse rate unfound, which is a little strange, but nonetheless, temperature, pulse ox, and dress in disarray. So how many systems can we count here? 6 for anyone? The answer is 1. Even though you have 7 pieces of constitutional information, you get credit for a system only once. Okay, here's another tricky one. You've got murmur documentation that indicates a cardiovascular exam and the abbreviation CCE. In this notation, is CCE plus the CV notation enough body areas or systems for an expanded problem-focused exam? And the answer is yes. CCE stands for cyanosis, which is blue color of the feet or hands, clubbing, edema, which is swelling. Physicians may use the medical abbreviation NO-CCE, for instance, to indicate adequate blood oxygenation in physical examination of the extremities. Therefore, you have 2 body areas or systems examined, both the cardiovascular and the CCE, counting as the extremities. And this would equate to an expanded problem-focused exam. An expanded problem-focused exam typically maps to the second and sometimes also the third level service component. On our 3 of 3 services, expanded problem focus is required for both new patient office visit code 99202 and the middle level consult codes, middle to low level 99242 and 99252, as well as the ED codes 99282 and 99283. On the 2-3 services, an expanded problem-focused exam is listed as a component of our old friend 99213, as well as for the middle level of subsequent hospital care 99232. The next level of the exam is a detailed exam. The tricky thing about a detailed exam is if you look back at the CMS audit sheet system data box, you'll see that both of them require additional systems up to a total of 7. So what's the difference here? You're not counting based on the 7. You're actually counting here based on the distinction that one is a limited exam and one is an extended exam. And that's all the detail that the 1995 EM documentation guidelines provide for you. So you have to look to see whether the physician goes further into the body area or system than usual. And this could indicate an extended exam. For areas that your physician regularly examines, be familiar with his usual detail. That way, when you see more detail, you can distinguish an expanded problem-focused exam from a detailed one. I had somebody who recently wrote to me saying that this is their major area of problems. And the real key is to be familiar with what is typical for your physician. What is he normally including in a limited exam, and what is he including when he is on the more unusual circumstances going into the higher levels of a detailed exam and doing an extended finding on a system. Here are some keywords you should look for that will clue you in to a detailed exam. For respiration, documentation will have the respiratory rate, assessment of respiratory effort, oscillation findings, and usually a reevaluation of the respiratory system. So if we have a patient who's coming in and they're wheezing and they require an inhalation treatment, and then you're having findings of what the pulse ox rate is after that and whether they've improved or not, and then you're seeing a subsequent inhalation treatment, typically you're going to be seeing a documentation that would be supporting a detailed exam. For a detailed exam of the abdomen, you'd expect to see how the abdomen looks, palpation of liver, the spleen, any body mass is noted, area of pain, degree of pain, such as on a pain threshold scale, vowel sounds, etc. If you're taking the EM or primary care specialty exams that the American Academy of Professional Coders offers, like the Certified EM, Pediatric, Family Practice, or IM Coder exams, make sure you know the difference between a limited and detailed documentation. Pay attention to exam findings that are longer and more detailed than typical area or system findings. These are probably detailed physical exams. Now, what difference does a detailed exam provide over an expanded problem-focused exam? A detailed exam goes on our 3-3 exams to our 99203, 99243, 53, 99284. It also goes to the lowest level of both observation care codes, 99218 and 99234. In the 2-3 category, a detailed exam is listed as our 4th level of EM service, also as our highest level of subsequent hospital care. Using the 1997 guidelines, you have to have 12 to 17 bulleted elements from 2 or more systems for a detailed exam. Let's look at how the examination affects the difference between 2 favoritely debated codes, 99213 and 99214. Using the 1995 guidelines, 99213 requires an expanded problem-focused exam, so 2 to 6 brief systems. For instance, documentation could include general or constitutional for alert and responsive, left ear clear, right fluid, this would be under our E&MT area, nose clear drainage, also under our E&MT area, chest clear, and no murmur for cardiovascular. So this counts as 4 systems examined, or 99213. We have our constitutional, these 2 both counting as our E&MT, our respiration, and our cardiovascular. Now let's look instead at a 99214. And right away you should be drawn to the respiratory findings and how much longer these are than what we were looking at when we were looking back at our 99213 area of respiration, which was findings of just chest clear. In this example, we see the patient having our typical, as I was describing before, problems with wheezing, rales and rhonchi bilaterally, patient in obvious respiratory distress, doing a neb, and then reevaluating. And then lower on, we're seeing in the documentation improved, but still having wheezing, another calculation of the respiratory rate, and then a final reevaluation. So here you have 3 systems that are brief. We have our constitutional, our E&MT, our cardiovascular, and then we have our respiratory in detail. And so that is the key factor in giving us our detailed exam level. The final type of exam is comprehensive. This requires a general multi-system exam or examination of 8 or more systems or complete exam of a single organ system. For the complete exam requirements, see the 1997 EM guidelines. Individual single system exam requirements, and you can find those at supercoder.com under the guidelines section. Notice on the CMS audit worksheet that the comprehensive exam detail indicates systems only. General multi-system exam, 8 or more systems, or complete exam of a single organ system. Unlike the other examination types, comprehensive makes no reference to a body area, whether a limited or extended exam of the affected body area. So here we have the affected body area or organ system, and other symptomatic or related, once again, organ systems, extended exam of affected area or areas, and other symptomatic or related organ systems, whereas here we have strictly 8 or more systems.